Respected Chairperson, distinguished delegates, dear friends, one morning to one and all. At the outset, my sincere gratitude to Dr. Jyotidev and the entire team for giving me this beautiful opportunity. Always, JPEF is one of the best academic fields regarding endocrinology in Trivandrum and all over India. So I think my slides have some, yeah, it's corrected. Thank you, the technical team, for correcting it. So, menopause and diabetes, when he gave me this topic and I brushed through the literature, I was also very much happy to see there are a lot of new things even I could learn from this particular topic. So this is a very important topic. We often neglect menopausal people or the menopausal ladies. We won't give much importance to the menopausal problems. So this is a very important topic. I think this is very useful for the menopausal age group ladies also. So what is meant by basically menopause? It is permanent cessation of the menstruation following the loss of ovarian follicular activity. So the last menstrual period is very important in a lady to diagnose menopause. So she shouldn't have period at least for the last 1 year. Then only we can call her as a menopausal lady. There is another period known as climacteric period. That is a period in and around menopause, either one or 2 years before as well as 1 or 2 years after the onset of menopause. And during this period, all the hormonal changes are taking place in her body, and all her emotional, physical, psychological, everything is happening during this climacteric period. So what are the hormonal changes? So as we all know that estrogen hormone is the wonder hormone for females, and the estrogen is supporting almost all organs of our body. Especially it is useful for the brain, it is useful for the heart and the liver, for the ovary, and for all the reproductive functions of the females, then for the vagina and for all sexual functions, for the breast, and it has a lot of effects on the uterus, and of course it has effect on the bone also. So what are the menopause? So when this particular hormone has this much of effect on the body, naturally its absence is complete cessation. Soon after the menopause, it will be completely cut from the body. So definitely the body will suffer a lot of problems. So that includes the headaches, hot flushes. Hot flushes means a feeling of heat sensation in her, and she'll be sweating. Even though the outside atmosphere is so cool, she'll be sweating like anything, and that is otherwise known as hot flushes. That's the most important postmenopausal symptom. Then the tooth might loosen. She is at risk for cardiovascular diseases, generalized body aches, body pain, then bone loss and bone pains. Then hair, the texture of the skin, the generalized beauty can be reduced. The breast, the abdomen, etc. will lag and become loose. And she will have the stress incontinence or urinary problems. She will be more prone for fungal infections, recurrent urinary infections. And of course, the vaginal dryness, itching, and all those problems will be there in her body. Other than this, the other problems of estrogen deficiency includes the osteoporosis, one of the painful situations. Then of course she is prone for the diabetes mellitus. Then as you all know that better than me, she will be prone for the ischemic heart disease, cerebrovascular changes. Then there is diabetes also. So why this is happening? So the same mechanism in other metabolic situations also. Naturally the metabolism slows down, and if you are not burning up too much of calories in you, naturally there will be weight gain. That is happening after menopause. And then especially much of the weight gain, as you observe the ladies, you can see that much of the weight gain will be in her belly also. So when the belly fat increases, the insulin resistance will naturally increase in her body. And this insulin resistance is a culprit behind developing diabetes mellitus in a menopausal lady. So these are some of the literature. Most of the literature are supporting the correlation between menopause and diabetes. But actually, diabetes cannot lead on to an early menopause or anything like that. But she is more prone. Nothing like that. She will get diabetes, but she is more prone for getting a diabetes if she becomes in the menopausal age. Of course, the estrogen and progesterone hormone is controlling all the homeostasis, and that will be lost, and she will be prone for insulin resistance and hyperglycemia. Another important thing, and there will be hormonal changes. These hormonal changes can produce blood sugar variations or fluctuations in the blood sugar in her body throughout the day. That's why you might have seen patients where in menopausal ladies you might have a difficulty in maintaining the blood sugar control. So that is because of the hormonal changes can produce the daily or hourly fluctuations in her. Then of course, she might get vain. I told you that she might gain the belly fat, weight gain and all, and that can make her prone for another risk factor for type 2 diabetes. Then she will have disturbed sleep because of the night sweats and other effects, and that also increases the risk of diabetes. These are all indirect correlations. Then most of the menopausal ladies will have some mood swings, they will have emotional problems, and they may take treatment for depression and all. That also increases the risk for diabetes. Then she will be more prone for the urinary infection, fungal infections, and of course sexual dysfunctions also. That is also distressing for a lady. Then when I went through these articles, I have seen an important correlation also. So you might have met ladies with the gestational diabetes mellitus. That means diabetes mellitus you are acquiring during the time of pregnancy. That is gestational diabetes mellitus. Whenever a lady gets gestational diabetes mellitus, she has an 8 to 10 fold increased risk of getting a type 2 diabetes in future. And that itself in the first 3 to 6 years after the GDM pregnancy. Especially if she is getting diabetes in the early stages of pregnancy, she is more prone. And if she has much glucose fluctuations during her pregnancy, she is more prone. And if her insulin requirement during pregnancy is also very high, or insulin requirement is also needs some fluctuations, so she is more prone for getting a diabetes mellitus in future. Similarly, if her blood sugar is uncontrolled, like she is having a microsomic baby or a polyhydramnios during pregnancy also, she might have an increased risk of getting diabetes in future. Then in addition to that increased risk of type 2 diabetes, there is a small percentage, around 10%, can have type 1 diabetes also in future. So what you can do is, as a gynecologist, as our general practitioners also, what we can do is, we can definitely subject them, or we can have to coax them to go in for glucose tolerance test. That's a 75 grams GGT itself, and as well as the HbA1c after 6 weeks of pregnancy, and she can monitor yearly also. Especially if she is obese or if she has a family history, definitely she has to monitor. Then regarding the menopausal age and diabetes, any correlation? As such, there is no correlation from the literature. Only from our practical experience, what we have seen is in infertility practice, if she is a diabetic lady, especially a type 1 diabetic or type 2 diabetic lady, especially type 1 from an younger age or something like that, then her AMS, that means the anti-Mullerian hormone, which is the predictor for the amount of X which a lady can have in her lifetime. So the AMS value will gradually decline than another person of her age. So gradually her reproductive lifespan will reduce, and she may end up in a premature menopause or premature ovarian failure. That's what we have seen. Some correlation we have seen in our infertility practice. So that is there. But if she has a typical premature ovarian failure, that means around 30-35, she is stopping her periods, definitely she has a risk of diabetes mellitus in future. This you might be knowing that definitely her cardiovascular risk and all those things will increase when the diabetes and all those, when she develops diabetes postmenopausally. So what are the choices? Of course, we won't advocate much of HRT in our women, but if she is diabetic and if her diabetics needs is not getting properly controlled, definitely you can offer her. You can refer her to a gynecologist to go ahead with a menopausal hormonal therapy or the HRT, hormone replacement therapy for the menopausal lady. And HRT usually required for premature ovarian failure patients. So type 2 diabetes mellitus can affect the ovarian aging according to the literature. Then MHT may be useful in type 2 diabetes patients, but if they are of the low cardiovascular risk group, you can advocate them to have oral 17-beta estradiol preparation. But if she has a higher CVD risk, then definitely better transdermal preparations or patches are available. Then you can combine oral micronized progesterone also with that. That will help to induce a artificial bleeding in her. That also will help to reduce the cardiovascular risk. But whenever you are giving an HRT, it should be an individualized approach, and it should be depending upon her other comorbid conditions, and consider a short period and a short therapy. That will be better. Once she is relieved, we can better taper it and stop it. Then estrogen can be delivered either orally, transdermally, or a topical preparation. Progestogens can be combined with estrogen either in a cyclical form so that she will get periods. That is better for the uterus, or can give continuously also. Then progesterone is usually used for that is protected to prevent the endometrial cancer and all, uterine cancer and all. Then several progesterone preparations are available like micronized progesterone 200 milligrams per day or dihydrogesterone 20 milligrams per day. Mirena is an intrauterine device which is delivering the progesterone like the copper T and all. That is also good for this age group. Then whatever maybe we can give in the second half of the cycle. That means you are giving estrogen in the first 15 to 20 days and second last 10 days or 5 days you can give the progesterone. So that she will get a natural periods like the natural, mimicking a natural cycle. Then commonly available estrogen preparations are the conjugated estrogen 0.625 and 1.25 milligram tablet, estradiol valerate either 1 milligram or 2 milligram, transdermal 17 beta estradiol preparations. Then patches are available, vaginal creams, we are using vaginal creams especially for sensory products. Then ligands like cereals, bran, beans. Then comescents like the chickpeas, pinto beans and all. Then phytoestrogens can reduce the vasomotor symptoms, can reduce the risk of CA+, can prevent osteoporosis not completely to some extent, to some protection to the heart disease also, prevention of heart disease also. Then androgens we are not routinely advocating, but if she has severe sexual dysfunction, if she is sexually active, even after 60 or something like that, we can give testosterone patches or something like that. The non-hormonal remedies, black cohosh, ginseng, these are only this non-hormonal remedies. Vitamin E is useful. Red clover, cavan, this might be there in most of the nutraceuticals. Then lifestyle modification is very important. That includes diet and the nutraceuticals. Exercise is very important and stress management. Coming to the diet, it's a balanced diet with adequate calories, macronutrients and micronutrients, high fiber diet, and there should be sufficient water intake, at least 2 to 3 liters of fluid daily. Then food should contain phytoestrogens. Then fermented foods like idli and all is good. Minimize saturated fat as well as salt. Supplement with calcium, vitamin D, magnesium, vitamin C, E, B1, B6 and B12, all these are good for her. Then food containing phytoestrogens includes carrot, beetroots, broccoli, peas, soya beans, soy-based products. Then apple, plums, papaya, pomegranate, cherries, cucumber. She should include all these things more in her diet than the other junk food and all. Food rich in calcium includes yogurt, milk, orange juices, soya beans, salmons, sardines, cheese. So physical activity is very important. At least 30 minutes moderate exercise daily. She can select the exercise according to her will and wish. Then every 10-minute sessions needed. Then weight bearing exercises are good for her. Aerobics. Then stretching exercises. Swimming is a very good exercise for menopausal ladies. A regular exercise can reduce the vasomotor symptoms like hot flushes and all, elevates her mood, increase the libido and sexual functions, improve the memory and concentrations, and she has a feeling of well-being after all. Stress management is very important as partners and colleagues and family members. Definitely you have to support her during this period. She might have a lot of psychological problems during this phase, lot of mood swings and all. Definitely a partner support is very important. So along with that, you can definitely advise her to go for meditation. Yoga is a good exercise for this group of ladies. Then hobbies, she can spend time in her hobbies and meditations and all is good. So last but not the least, whenever a lady attains menopause, she never thinks that it's the end of her life. Treat it as she has become matured. Take it in that way. So she has freedom from periods. She can participate in any religious activities. She becomes a respected figure of the family. She will be everywhere, and she can be a good grandparent also. Take it in the positive way, so she can minimize the confusions. To conclude, the menopausal hormone replacement therapy is useful to reduce the menopausal symptoms, but it should be given in the short period and lowest effective dose and gradually taper. And alternate non-hormonal therapy also you can advocate. Menopausal transition is a good time to execute healthy lifestyle for her. That will be useful for you also to reduce the comorbid conditions in her. And post-menopausal women is more prone for diabetes and related complications. In India, we have a menopausal society. So we are there taking care of these menopausal ladies as well as conducting conferences for the gynecologists and all. So thank you all for your patience here.